Good afternoon, everybody. Thank you for the opportunity to present here today. And today I want to be discussing a case of mechanical valve thrombosis. So we'll start with the case. This is a 40-year-old woman with a history of a 29 millimeter carbometics mechanical valve in the mitral position that was implanted back in 2006 as a result of having MSSA endocarditis. The patient presented to the emergency department with 2 weeks worth of chest pain and dyspnea that had been worsening over that time period. On initial evaluation, the patient was visibly in respiratory distress, hypotensive, cold and wet on exam, consistent with what we felt was the presentation of cardiogenic shock. Her medical history included a pregnancy-associated dilated cardiomyopathy, the endocarditis that I described leading to the mitral valve in 2006, as well as a BMI in the 40s, prior tobacco use, hypertension, and these other cardiac conditions. Home medications included warfarin for the mechanical valve, as well as guideline-directed medical therapy for cardiomyopathy. Initial notable labs revealed evidence of end organ hyperperfusion from her ongoing shock state with an AKI, acute liver injury, supratherapeutic INR at 4.5, and an elevated lactate. The patient was quickly triaged to the CCU, where she required intubation, initiation of inotropes, as well as aggressive IV diuresis. Initial transthoracic echo revealed severe biventricular systolic dysfunction, mild aortic regurgitation, and most notably for her, newly severe stenosis of the mitral prosthesis with a gradient above 20 millimeters of mercury. APA catheter was placed in the CCU, which showed severe elevated pulmonary pressures with a wedge in the low 60s, which I think is the highest I've ever seen. TEE following that transthoracic showed obviously turbulent flows through the mitral valve, as you can see here on the collar Doppler. On 3D reconstruction, our surgeon's view, we can, I think, clearly appreciate how the valve doesn't really open the way it should. You have one aperture on the left side of the screen, but then the other one is completely occluded. And our TEE confirmed severe transmitral pressure gradient in the low 20s. So here we took a step back and decided to have a heart team discussion as far as what would be the most appropriate treatment therapy for this patient. The guidelines essentially recommend 3 different approaches for patients who come with mechanical valve thrombosis. The first is an approach of optimizing anticoagulation. This is typically more for patients who come in with more stable clinical condition, who may have signs or symptoms of heart failure, are symptomatic from this, and more commonly have a subtherapeutic INR, which was the opposite of our patient. She came in with a supratherapeutic INR. So this was probably not the best option for her. Another option is to employ thrombolytic therapy. This therapy usually is employed in a way where the patient is given a low dose and slow infusion of TPA, typically over a course of 25 hours, with repeated infusions as needed in order for the patient to see some clinical improvement, and monitoring with repeated echoes as well. And of course, we have the last option, which would be taking the patient back to the OR and replacing the valve altogether, which would give us a definitive diagnosis and treatment. At this time, given this patient who presented in extremis, continued to worsen given her medical condition, we felt that obviously anticoagulation would be insufficient treatment for her. Thrombolytic therapy likewise requires a long duration of infusion of TPA, and she also had a very high bleeding risk, coming in with an INR of 4.5. Most of the trials that have looked at thrombolytic therapy have also only looked at patients who had an INR less than 3, and it was never studied with patients that had an INR above that. The surgery team at the time also felt that, given her condition at the time, that she would be very high risk for surgery and would likely not survive it. So we were at odds about what to do, and after further discussion, we decided to take the patient to the cath for transcatheter leaflet release. So we took the patient to the cath lab. A cerebral embolic protection device was pre-positioned, and then we gained access to the left atrium via transeptal approach, as you see here. We then placed an Agilis deflectable sheath facing the mitral valve. This is a nice shot, an orthogonal view of the valve where you can really appreciate how one of the valves moves while the other one is clearly immobile. And we proceeded to try and open the valve by simply pushing that leaflet open. As you can see on the left side, we inserted a catheter through our sheath and tried to push against this leaflet, but it would not give. We next tried 0.035 stiff wire through that deflectable sheath, and likewise, as you can see, as we're pushing on the leaflet, the entire sheath gets pushed back. So we were ultimately not successful in doing this. Lastly, we tried a smaller stiff wire. This was an Astato XS20 stiff 0.014 guide wire. And as you can see on the left, in the fluoro imaging, we were able to pass that wire. The 3D reconstruction here confirms that the wire was passed at the aperture between the stuck leaflet and the mitral valve ring. And then we proceeded to do valvuloplasty by using sequentially larger non-compliant coronary balloons, starting with a 1.2 millimeter, which is actually compliant, and then a 2, 3, 4, and 5 millimeter non-compliant balloons until we finally got to this point, where we now see the valve leaflet is opening and has near normal motion, as can be seen both on fluoro and 3D imaging. At the end of the case, the cerebral embolic protection device was retrieved, and as you can see, we appreciated a lot of thrombus debris that was captured.
Oh, good.
Off-label use, since it was for mitral valve. The patient did very well afterward. At the end of the case, the mean left atrial pressure dropped from the low 30s to the low teens. Her wedge dropped from the low 60s to the 40s. She went back to the CCU, was quickly extubated after that, weaned off inotropes, and actually did really well. We continued monitoring her with serial echoes, seeing how she responded to the intervention until near discharge. We actually got an echo before we sent her home with a normalized gradient without need for any further intervention, lytic therapy, or any kind of surgery.
But anticoagulation for sure.
Optimized anticoagulation before discharge.
Okay,
Correct.
good.
Wow.
Very nice.
So
Very
with that,
nice.
I'll just leave you 3 take-home points. Mechanical valve thrombosis, when obstructive, can present in extremis, and you should keep a high index of suspicion in patients that you know have a prosthetic valve. The guidelines recommend 3 different strategies: optimizing heparin anticoagulation and warfarin anticoagulation on discharge, thrombolytic therapy, or redo surgery. But you should consider transcatheter manipulation to release a stuck leaflet in cases where these 3 therapies are not options for your patient, or in cases where you think that you could intervene as a bridge to surgery and definitive therapy. Thank you.
Any questions from faculty? I mean, fantastic case. There, used to be original St. Jude's with a tilting disc when people try to cross by mistake inadvertently, or pictal catheter or so, the leaflet used to get stuck. And clear, we never crossed by the metallic valves. I mean, in the aortic position. I mean, mitral is not needed, but I'm saying in the aortic position and so. So it's the same thing to the mechanism that you can release those just by the mechanical manipulation. It's a true mechanical thrombectomy to release the defect.
Well, I think the most important thing was cerebral embolic protection here, and
Correct.
we've been talking about it all day, and so here it is. Art?
Just in terms of, is the thrombosis, or is it, I mean, does the patient need a redo operation, or what's the long-term strategy for management?
Yeah, so the patient leading up to her admission had normal transthoracic echoes. This valve had been implanted in 2006, so there's a lot of transthoracic echoes that had shown normal gradients. Her symptoms were very acute within a 2-week period, which I think guided us in a direction of more, it's probably thrombosis. And I think once we got the transesophageal echo, we could kind of more clearly see that it was really one side of the valve that was giving us a lot of trouble. I think usually for pannus, formation, that tends to be more circumferential around the mitral valve ring. As you saw on the transesophageal echo, it was more one-sided and really affecting one of the 2 leaflets. So we felt that it was more likely thrombosis, and hence trying the leaflet release. The patient has actually done fine and has had outpatient TTEs showing normal gradients.
Wonderful. You have a
Last
question?
question.
Sorry to to follow up on the same. The mechanism, if this is thrombosis, how can we tell that it won't happen again? Because the INR was 4 when this happened.
Now, this is a good question. So we're not sure if the patient maybe had a transient period where the INR was actually subtherapeutic, and then when she developed her shock state, had hepatic dysfunction and became, higher bleeding risk. On discharge, I don't remember, but I believe what the team decided to do was discharge her on low-dose aspirin on top of the warfarin.
All right,
Thank you
great.
so much, Cesar.
Thank you.
I think we can move on.